Well, thank you. Hello from my side as well. Hello to everybody. My name is Wendy Awa. I am a technical consultant for health matters at the head office of GIZ at Eschborn. My background is in public health, and we cooperate in the team with Alexander Hobinka and in the Competence Center for Health, Social Security and Inclusion. And I've been working in that department for 2.5 years. Before I used to work at different universities. Well, thank you, Wendy. Just to supplement that, it's not only social security and inclusion. It's great that you have first mentioned these two topics, but health is also a topic for the Competence Center, and you are the one, well, you are the expert in the field of health. Well, thank you for inviting us to participate in your international conference. My name is Alexander Hobinka. I work mainly on inclusion at the level of GIZ. I look at the different methodologies, and in a cross-sectoral approach, I try to do the mainstreaming of that topic in the different sectors, health, urban development, governance, occupation, and employment. That's why I look at that topic from the mainstreaming perspective, but that is not really relevant today. So what do we intend to do? We try not to be too long, because we would first like to give you an overview of core documents, reference documents for our work, to have the link, and that's what Wendy does, of the concept of universal health coverage, and we heard a lot about that already today, and the link with disability, the connectedness between these two topics. Then we want to give you a few examples from technical cooperation at the project level, experiences from the field, and then a few key challenges that we see for our work for the future, and potential that we have identified. Let me start with a brief overview of the framework, the reference documents on which our work is based. For example, the United Nations CRPD as the binding document for our national GIZ, an opportunity for us. Also, the Agenda 2030 was the guiding principle of leave no one behind. Then, and that's for us, the data situation, which is a bit outdated, but is still relevant as a reference document, World Report on Disability of the WHO and the World Bank, which for the first time has given us a basis regarding data that is internationally comparable. And another initiatives and network, is rather a network than an initiative, is the UHC 2030, Healthy Systems, Healthy Lives, where we want to form an alliance, a partnership between multilateral and bilateral partners to give more attention to UHC and do some advocacy and lobbying work. So these different framework documents are the resource or the basis that feeds into the new BMZ strategy for inclusion, the Ministry for Economic Development and Cooperation. So we do some sort of translation work on a daily basis, and there's still a lot of leeway. We can still improve a lot, but that's what we all know, but that is the basis for what we actually do. And now I move on, or I pass on rather, to Wendy for the theoretical part on universal health coverage. Well, Alexander, thank you very much. In the other presentations, we've already spoken about the universal health coverage, that it has the aspiration, or is the aspiration, that all people have access to promotive, preventive, curative, rehabilitative, and palliative health services that they need without falling into financial hardship or poverty. I don't want to go into the detail here. And we've also already heard that lots of people worldwide still don't have that access to basic health care of good quality, and that millions of people still have to co-fund their health services and therefore are exposed to poverty. And we also heard that people with disabilities are much more affected to fall into that poverty trap than people that don't have any disabilities. Alexander, next slide, please. So I can only repeat what has been said already. Persons with disabilities have, of course, similar health needs to as everyone else, but they have additional needs, and that the access barriers for all three UHC dimensions can be strongly felt, which means they are excluded from certain services because these access barriers are of physical nature, of financial nature or other. They are barriers because of discrimination or the different health services or the more complex health care that they need is not available at all. Sometimes the medical staff on site does not have the necessary skills and competences to give or to provide healthcare to persons with special needs. And the aspect of intersectionality has also been mentioned several times. Gender, age are factors that are special challenges. We already had a presentation on the situation of women where health care is not given adequately. So very often people with disabilities have to bear part of the cost of the health care, and that of course pushes them into poverty. It leads to social exclusion, and the disability is always an additional challenge. The risk is then that their health situation does not improve, but that it declines even further. So there is no adequate response to the actual health challenge. This has also been mentioned. There are physical barriers to health facilities that make certain facilities inaccessible. There's a lack of services. The questions relate to stigma, attitudes on the side of the health professionals, communication problems, a lack of information material that meets the special needs of persons with disabilities and address these needs are lacking. All of that has already been mentioned. Or they're not always available. Costs is also a question that was addressed. We heard that when it comes to rehabilitation measures, a lot of services are not covered. The universal health coverage systems do not include certain services for persons with disabilities because of their age or because of the fact that they're not part of the general budget or not physically available. That means that persons with disabilities have to co-finance the services, and that leads to catastrophic expenditure. Often, persons with disabilities are not covered by insurance schemes, and data is lacking who these people are and what services they need, so that an adequate response could be found. What can we do to fight this problem? That has also been mentioned today, so-called disability mainstreaming. The associations representing persons with disabilities need to be included into the planning processes to include the specific needs. The services that are needed must be adequately resourced. Reforms and mechanisms need to be defined in a way that additional needs when it comes to rehabilitation are included. This also goes for assistive devices, and that once again data needs to be provided to have a high level of accountability and the possibility of monitoring regarding the progress that is made. So data collection is needed. That also leads to the identification of gaps and good monitoring. Awareness, another very important factor. The fight against stigma and communication barriers. I mentioned already the data issue to identify critical bottlenecks. Once data is available and aggregated, we can then address the critical points and bridge the gaps. Well, I pass on to Alexander. Thank you very much, Wendy. Very briefly, some insights into a number of projects or processes where we would say, well, here we've been successful. We've been able to anchor inclusive approaches in our work, and we have well prepared the ground for successful activities. Well, this is our portfolio of the Ministry for Economic Development and Cooperation. Before going into the countries, you see a pie here where in Sub-Saharan Africa, the MENA region, and Asia, we have the largest number of projects. Well, there's a main regional focus of the BMZ. There are lots of projects in the field of flight and migration, transition, employment. And here, the topic of inclusion is always a factor. Again, this pie chart to show that health is not one, unfortunately, not one of the main areas of activity. There's still a lot of leeway and scope for improvement, and the question for the future would be how, and as a result of Corona, we could get more attention to that topic and dedicate more resources to finding responses to that topic, and inclusion should be always entailed. We've got other sectors that are more important, like state and civil society or employment promotion and labor markets. For the time being, that was the situation in May 2020. We have a total of 116 projects that are inclusion relevant, or where inclusion is one of the main factors in the project. Well, now on the practical experience in Cambodia for a number of years, we have built up a link with that topic of inclusion. The background is that a study on barriers to accessing healthcare for persons with disabilities to find out what barriers do actually exist. And the study led to a situation that the project gradually developed more and more inclusive approaches. So what have been the different activities? It's a very hands-on work that I'm going to present you, but that may be interesting to you. For example, the possibility to take over transportation costs for people with disabilities and for their families to take them to the health institutions or facilities like medical centers or rehabilitation centers. Then the modification of the health facilities, barrier-free or low barrier access to the different health facilities. There was a study, and that was of great relevance as well, a study on health expenditure, where we've been able to show in what way additional expenditure reinforces the difficult situation for persons with special needs, because these different activities are very expensive, and that means that a lobby is needed. The Ministry of Health then needs to adapt the different policies to say, well, in the budget, in the national budget, we need to allocate more resources to additional services for that specific target group of persons with disabilities. Then regular training and quality assessment is carried out for health professionals, also in view of their competence and know-how for the rights and the needs of people with disabilities, because that is a first step towards raising awareness and to learn how to deal with these special needs as a professional in the health sector. And lessons learned, the involvement of DPOs as a lobby organization in the planning and implementation of health interventions, that has built up a lot of positive pressure among the state actors, but also on the side of the GIZ. And the dialogue between the different ministries, the administration, that the different medical centers, and all the way up to the national policy making level, forces were joined and a dialogue was started. A second example is a project in Guinea in the field of reproductive and family health. It's a program where the current phase continues until 2022. Here we also saw that the data situation was improved. The health project was very sensitive to that analysis of data. So we looked at educational and health activities, GIZ and CBM, which has a good network on site, and worked as a mediator between the different self-help organizations, and GIZ was very important. And that sort of actor analysis triggered lots of exciting, interesting interviews and provided us with data to find out where the actual lack was. Two focal points were identified as a result that looked mainly into the topic of inclusion. They were to disseminate knowledge, but they also served as monitoring points to identify what actually happened in practice in the field of these different health projects. And there was strong support by the national DPO Federation in Guinea. They served as experts and became very active to support the needs of their members. Success factors, well, the strong commitment, you always need a strong commitment, strong support of the different actors and the program coordinator. It could be state director or program manager. You need clear communication structures, points of communication, people that have time and a budget to build up something in the field of inclusion as part of the overall project, or also ideally in the entire GIZ structure. And then, of course, you need to effectively involve the disabled persons organizations, the DPOs, from the beginning to end to ensure the success of any such project. Well, last but not least, the Kyrgyzstan project or the portfolio analysis, Kyrgyzstan, Uzbekistan, that is linked to this project. In this health project, there was a overview study in 2017 on the mortality among vulnerable groups, including people with disabilities. That helped us to identify the need and potential for inclusive perinatal care once more. As a result, the access to gynecological care for women with disabilities has been improved. We heard that already this morning, that there is still a gap here, a lack, or there are still insufficiencies, not only in our partner countries, but also in Europe. And then right afterwards, a capacity building and awareness raising on the importance of inclusion among the health professionals and also the parents of children with disabilities, for example. So both groups have been integrated into the set of measures. And the most important lesson learned is the study that was carried out in 2018, an analysis of all major projects of GIZ in Kyrgyzstan and Uzbekistan has shown identified the potential for concrete inclusive measures in the different programs. And it has become very clear as a result of that study that we do not only have to explore the situation of people with disabilities in the country, but we need to clearly link that to the question as to how our projects can give an answer, can be a response to that need. How can we be more inclusive in our respective projects, including projects in the health sector? Well, I think that's more or less the most important. Maybe very quickly, the challenges for technical cooperation. We see a major discrepancy between the rules, or the legislative provisions, and the practical implementation of the law. We've got national and international standards, but they are not sufficiently taken into consideration in the implementation, which is not a bad intention, it's a lack of knowledge sometimes, and we need to improve here. Then a clear point which was raised repeatedly throughout the day, what we call the data gap when it comes to disaggregated health data on people with disabilities and health issues. So there is a lack of data, and the projects can improve the data situation. But that is a different challenge altogether. But that's often an obstacle, major obstacle, in order to pursue evidence-based approaches. Another very important point is how to address the target group in an adequate manner. And here I think the LNOB principle can help as a guiding principle, which hopefully will be executed more strongly by the ministry. And the GIZ, and here I'm involved, we have developed a tool which is called Tree for Option, where the mainstreaming of that LNOB principle is put to the fore. where the project staff click themselves through an interactive decision-making tree to see where they stand, which measures are still on, where is the potential, which tools can be used, which measures need to be formulated. And they get support by the headquarters. So it's a very promising approach to do more justice to that LNOB principle. Then the twin track approach, mainstreaming approaches as well as specific approaches for mainstreaming and empowerment activities do have to play an important role in any project of the GIZ, and then involvement of representatives of DPOs and of civil society in the respective countries as experts and partners. That should be a key task for our work as well.
And also at the end, the strategic anchoring of our programs and projects is very decisive. There are processes where we can adhere to the corona response by and especially at this moment, there's room for it because our target group plays an important role. There's a new global initiatives on One Health that would also offer some opportunities to include the subject. You should always underline the lack of knowledges and also offer technical support to the colleagues when they ask for it, even if they don't ask for them, offer them trainings, for example, thanks to the 3 for options tool and other relevant subjects such as UHCs that's been extensively discussed today, the COVID-19 and pandemic response that would merit really one separate event, and also rehabilitation that has played an enormous increasing role in the migratory refugees context, and that is really, really important also for the health policies, meaning taking care of psychic health. That should play a greater role in our own projects. And finally, last but not least, maybe you know this debate on the 2030 Agenda 2030 process within the BMZ. As I work very strongly on inclusion, I have a lot of hope in these new inclusion criteria that are about to be developed within the BMZ. We, as representatives of the BMZ, hope to be able to contribute to this and really discuss these subjects of gender and inclusion and human rights. At the same time, I think it's a huge opportunity. And the question that we should ask ourselves might be, how will it be integrated in our work? Will it really be mandatory? But this is a debate what we should like to have influence on. Also, civil society should have an influence on this. So there's some way to go still. This is all from my side at the moment. Thank you very much for your attention. And we would now like to give the floor to Gabi, if I understood it well. Yes, exactly. Thank you very much, Alexander Hobinka and Wendy Awa. Can you hear me? Well, perfect. We will now be able to launch the promised Q&A round. And the question will first of all be, are there any comments, questions concerning this presentation? I have a look around here in this room. Helena will check in the chat whether the online participants have questions or comments. So all the online participants are asked to put their questions in the chat, to do their comments, and please go to the mic here in the room so that you can will be heard online, and that the interpreters will be able to translate you. Please introduce yourself very briefly and mention also the organization you work for very briefly. Yeah, approach the mic. Maybe the mic should point to the screen. No, it's. Can you hear me? So you can. Please, louder. Thank you. Thank you very much for your presentation. I have a very practical question for you on the subject of data collection. In many different areas, you would simply say, we promote the use of the Russian group questionnaire as a non-specific screening method, but simply to collect data on disability. I'd like to know what the GIZ experiences are in your health projects. Do you propagate it as well? Because it's not so easy to collect this data in the health sector. What are your experience on this subject? And I have a different subject that I'd like to discuss also within our working group on the subject of disability. If you consider the subject of disability as a huge group of people with disabilities who are concerned, but it's not a fixed number of people concerned, linked to what is happening at this moment in the world, also linked to conflict developments, climate change, etc. The number of people with disabilities increases or decreases depending. And when you talk about inclusions, we should also have to talk about the prevention of disabilities, especially linked to the climate change, conflict zones, etc. Especially as actors on the ground, we want to promote, and how do we want to promote the independence of countries, etc. And we should also consider the fact in how far we are responsible for people with disabilities and for their chance and opportunities to be able to participate in the development and these their countries, especially when we consider the fact that obviously their number is rising among Syrian refugees. We have a prevalence. We have of people with disabilities that was more than 22% of these people who lived in Lebanon, meaning we always base our work on these so-called 15%, but somewhere, as we see here, this number of people with disabilities can be much higher depending on the situation. Who would like to react to this comment? Would you like to talk about data collection in the health context? Yes, I will try to answer your question. Can you hear me? Yes, okay, great. Well, as far as data is concerned, in the planning of our projects in the individual countries, we always have a look at median data from the GIZ, and they are also criteria for digital analysis. So for all parts of the projects, we have to have a look at the type of and number of data that we have when we start a project. We have a team for that. And you have also the expert competences within the country. in our health project team, and these data is collected in cooperation with the health sector on the ground, in accordance with the partners, according to the priorities in the system, and according to the context, the country. And we also take into consideration which national indicators are available, which data we have depends on the country, but all this data plays an important role, and the collection in the project planning, as far as the project planning for people with disabilities is concerned. If a project has not a certain focus on this group, well, we often find a lack of data and automatically then collect these data when planning a project, because these inclusion criteria are part of our requirements in so this should increasingly play a role in our planning and in the implementation. As for the second questions, the number of people with disabilities increasing, the number of fragility, etc. We have two pathways. We have the bilateral program and a program for a transitional aid, where the number of people who live in instability and maybe suffer also from disabilities is higher. Our experience, for example, in Libya was in these primary health care projects, in the operative plannings for primary health care. We invite in operative planning health representatives that are active at national level in order to highlight regularly with the deciders the special needs of people with disabilities. That is what I can tell you for project planning. But in the running projects, I have not much experience with the for the fragile contexts, and in what way the needs of people with disabilities are taken into account. But of course, gender aspects and other aspects, and also vulnerable groups are always specially addressed and included in these projects, but we always try to collect data on these specific needs. Can I give an additional information very briefly? Yes. Very concretely, I think spontaneously about projects. For example, in Cambodia and Indonesia, we had launched a vulnerability study in the context of social security projects. And in this context, data is collected in order to point out these vulnerable groups and have data and arguments to say that we do improve and increase our efforts for them, and it works partly very well, not everywhere. But as for myself, whenever I see a project and then the baseline study shall be launched at the beginning or for preparing a new project or program, I would always plead in favor of collecting disaggregated data for on people with disability, which is an important factor. It depends often on the initiative and responsibility of the project manager, of the expert technical planner. Just one word on prevention, which is also one aspect. Gabi, please correct me. Prevention is included in the BMZ strategy on inclusion and should be part of the different measures. Prevention is part of the inclusion strategy and should always be taken into account. I think about two projects spontaneously in Palestine and Syria, where there's a talk about the prevention of long-term psychic problem. Prevention is an important aspect. Maybe I can answer to this. I do not remember clearly that the prevention really plays an important part in this inclusion strategy. Maybe I'm wrong, sorry. Maybe in other contexts. Those who work in the development programs, the BMZ works very strongly also in the area of vaccination, but for us, it is also important, and you always have to take care. Our focus should always be how can people who have some kind of impairments have access to good health services. That's also the focus of today's events. And also how to prevent disabilities, impairments. If you ask this question well, you can enter a very complex debate. And for example, prenatal diagnosis in Germany, that's really a subject apart. So prevention, well, I do not remember that it's included in the pre-inclusion strategy, which is mainly focused on the equal participation of people with disabilities. That is part and a real focus of the inclusion strategy. We have now 2 questions from online participants, and I will give the floor to Elena that will read them to us. Yes, of course, in English. The first question.
That GIS has already been working on achieving disability inclusive health. Are there specific plans or initiatives on disability inclusive health that GIS has for the coming years? Übersetzung notwendig? Es ist sehr großartig, dass die GIS bereits daran gearbeitet hat, eine behindertengerechte Gesundheit zu erreichen. Gibt es konkrete
It is great that the GIZ has worked on the inclusive health strategy by the GIZ for people with disabilities. Are there any specific initiatives in this respect for the coming years? Well, the colleagues seem to think about how to answer this question. Maybe we can hear the second question. It goes into the different... who asked the questions? Well, it's anonymous. Well, so to all the participants, please tell us your name, introduce the organization. It's interesting to see who participates. It seems there are 46 participants here in the room.
Since early 2000 in Cambodia, do we have information what actions been done since then to know? It seems like not much, because after 2 decades the problems are still the same for people with disability. And do you think situation will change based on the results in the research done recently? Übersetzung wäre: Die Probleme, die seit Anfang 2000 in Kambodscha als Herausforderung aufgeworfen wurden, haben wir Informationen darüber, welche Maßnahmen seitdem bis heute ergriffen wurden? Es scheint nicht viel zu sein, denn nach 2 Jahrzehnten
That was the translation. Maybe you can answer very briefly to this question. Wendy, could you answer the first question? Yes. We need to part on the fact that a project is not applied on the whole country, but I've researched some information and it's based on the experience of the colleagues in the different projects. And I have to be very modest when I say, of course, we cannot change or revolutionize our whole health policies, but we can contribute to changing it. It is not up to us. It's not in our hands to change it entirely. This would be my answer. Maybe I can add to this. The quality criteria that have been mentioned in the presentations, meaning that inclusion is a quality criterion, this part of the Agenda 2030, that it is taken into account in the planning of the different projects. It's always been analyzed in how far they are really inclusive. And of course, the needs of people with disabilities are always taken into account. This is what we can say for future planning. As Alexander has already said, the projects themselves do not concern the whole country. Maybe it's only in one project regions that measures are implemented. And maybe not each and everybody who in the country who actually have the need will be reached. And they are also developed together with the partner countries and partner regions. And what is implemented on the ground is what finally can be implemented within the project phase together with the partners on the ground, as I said. And all the partners address these questions. Just one offer. The person who has asked the question, maybe I can set up the contact with our colleagues and do some research on whether there is any result reports or anything. Maybe I can set up a link, a bilateral link with a colleague who work on these questions. That might be a suggestion. Okay. For the contact to be able to set up, maybe the person who has asked the question in this chat can send it to us and then send it to you afterwards so that you can set up the link. And there's another question. Are there any further questions in the chat or here in this room on this subject? Yes. Please join the microphone. Hello, I'm Sabrina Elam from Handicap International. I work for the project Phase 2 Leave No One Behind. Thank you very much for your presentation. In our project, we work very strongly on humanitarian aid. This is why my question will be a comparison. You talked about the Corona response initiative by the BMZ. I would like to know whether in which way the disability inclusion plays a role. There was also the response plan on the COVID-19. There was a lot of pressure set up by also from the side of civil society in order to take into account the needs of people with disabilities. What about the Corona response initiatives launched by the BMZ? We've also talked a lot about quality criteria. I'd really like to know what does it actually mean? And how do you, as GIZ, try to make them mandatory so that those criteria also apply to those organizations who want to take part into project, that they really work on this and not only tick a box, but really implement activities that lead to higher reinforcement of activities, higher empowerment, and more self-autonomy and capacity building for people with disabilities. Thank you very much for these questions. On the one hand, on the immediate response program or to Corona launched by the BMZ, and also to the quality criteria and their practical implementation. Who would like to answer? Maybe both of you? As for the quality criteria, I could answer to that, but also to the other question, maybe it's not sufficient for our colleague here. Concerning the quality criteria, first of all, I can say that indeed, this is a BMZ internal process. We have not been totally integrated in these commitment, but from our side, we prepare a few ideas, especially concerning the quality criteria. One, human rights, quality, inclusion. We think up and think about the different frameworks, and we want to include what we want to offer. We want to be able to be ambitious, at least as for myself, concerning the subject of inclusion, in order to give the same space as the subject of gender equality, etc. But I think it's the same ambition as in the BMZ, that to launch and relaunch the subject of inclusion and put it at the same give it the same priority as the other important subject. That is our daily fight, I would say. As far as the Corona response program is concerned, we've shown it to you on the slide on potentials, because I believe in this context that there's still a possibility to improve ourselves, from my personal point of view at least, and so meaning we should really improve it and try to introduce the subject whenever it's possible. There is a community within the GNZ and the LNOB, and we try to do some lobbying for the subject in favor of it within the GIZ, especially in the context of COVID-19. We have also written an internal position paper, which we always use as an argument for our debate. But finally, it's up to the BMZ to decide. This is our reality. But nonetheless, I think there are people who support us within the BMZ, within the GIZ. When we think about Corona response measures, inclusion must always be on the agenda. There's no exception, no excuse not to include it. I can only add that via digital data collection, we collect data that include also target groups such as people with disabilities, to make their needs more visible, and also show which of our measures reach those different target group. It is part of the project planning on the GIZ side, and also act and adjust then the GIZ. We always highlight the need for it, and on the ground it will then become a reality. And on the ground there has to be higher effort to make these needs visible and also included in the evaluation of these different projects. Just some add up. During the last few months, I had 2 or 3 projects on my agenda that had to be evaluated, and in inclusion perspective was clearly included also by the colleagues on the ground, and it's all still partly due to the initiative and efforts of these colleagues to put it on the agenda. When they do it, it generally is adopted by the BMZ to be in a positive way. So everybody's got his or her responsibility for doing though. So maybe I will permit myself to add a remark or two. I think it is very positive, and there's a very self-critical point of view on how inclusion is part of the GIZ and BMZ programs, and it also to say, well, it's also on the shoulders of the program managers. But when we still see that we still have the UN Convention, we have the obligation to implement this inclusion, and when it shows that it's not not part of the agenda of all GIZ or representatives. So we also have to make sure that all project managers take up these responsibilities. If you say that there's still room for improvement, it makes that we have to improve. As for the Corona immediate help program in our help group was set up when this immediate help aid program was announced. There was a statement sent to the BMZ by the different stakeholders to include the needs of people with disabilities. So we really we included it, and we hope that it really has an impact on the project itself. And as you say, Corona immediate help measures have to include people with disabilities. It really has to be implemented on the ground. Hopefully this works. We will now give... Now we have a question of you, Sunderland from Humanity and Inclusion from Uganda.
Result on study in Cambodia, for example, has been known since early 2000. Do we have information on what has been done or not to ensure access and inclusion of PVD in national healthcare UHC? Do you think knowing that would help tragic actions to lead to making health inclusive? Auf Deutsch, die vorgelegten Informationen.
In German. Do we have information on what has been done and what not in order to make sure that the inclusion of people with disabilities is included? Wouldn't it help in order to make health more inclusive to do so? Who could now make a statement on this? Well, I have to say again that I have hope in this new BMZ strategy that would have been unthinkable 10 years ago, that clearly tells the German policies that inclusion is a cross-sectoral principle that has to be applied, linked to the hope that there will be also in the future practical, concrete implementation plans on the basis of budgets, staffing, etc. You will be able to measure and accompany what has been really be implemented, that the strategy will not stay as just only a position paper, but that the implementation really takes place. This is really an essential aspect in order to make this health strategy more inclusive. That it shall be cross-sectoral for health, for social security aspects, etc. And maybe another aspect, the last aspect, this quality criterion. As Wendy has also already said, is for us a possibility in order to give some orientation to the projects, to others would say to hand out some obligations to make sure that among others, all other subjects, also the health projects are more inclusive. Well, let's have a look at our presentation again. We see that the inclusion projects in the health sectors are only by 9% right now, and the measures implemented up to now always concern education, professional training, social protection projects. It reflects the needs, meaning there are only few projects in the health sectors that have the specific focus on these needs, but they are partly included. Vulnerable groups are partly included in health projects. So we would really have to measure in the end which projects really reach vulnerable groups or other groups with certain needs, with disabilities or other needs. It's also always a question of data. It only concerns a small number of projects, the minority of projects, I would say. Now, again, the fixing new political priorities in the framework of COVID-19. As I said, in the few years ago or up to last year, it was unthinkable that the focus is on health, the inclusion in health projects. And right now, we have really the possibility also to increase a portfolio in health projects, and also answering to the question of leaving no one behind. There was somebody here in this room who would like to intervene. Please, very quickly. We only have a few minutes left. We cannot work on the main question, but I think it was a good idea also that, to give you the floor. Thank you.
Vergessen meinen Namen.
Well, I forgot to tell you my name earlier on. I'm also from Handicap International. I'm a bit insisting, but we talk about data collection a lot. And as Mrs. Cooper said, what is not counted doesn't count, and has an incredible influence on our intervention and our programs. And therefore, my question once more, what does GIZ recommend regarding data collection, disaggregation of data when it comes to disabilities? Do you propagate the working group questionnaire in the health sector? Do you tell other organizations, ministries, governments to cooperate with them? Or what is your recommendation to that end? But in the health sector, it's not as simple as that. Therefore, I would like to know in more detail, what is your point? What's your argument? What do you tell your own colleagues? How to collect data in the projects at the project level? What is the status quo at the level of the GIZ? I would like to know more about that. Well, thank you for the question. Well, I personally would say, well, that's the minimum standard, the Washington Group questionnaire. I would recommend to use it. Whether or not my colleagues use it is a different question altogether. So there is no binding standard of use of that analytic tool. So that's a clear answer. And I could not say, I need to look into the documents, which fora or which entities use it, but I see your point. And I agree with you that we need a data policy to say, well, this aggregation of data needs to be included. However, we are a specific group within GIZ that demands this, especially those that work in the field of leave no one behind, and the gender researchers as well. Unfortunately, the colleagues working in the field of human rights respects as well, but we need to do some lobby work within the institution, within GIZ and BMZ, and to remind our colleagues that this is a bit more complicated, a bit more complex, but that it's important in order to make sure that those groups are on board that usually are neglected or forgotten. Wendy, do you want to add something? No. Well, thank you very much. We are at the end of our working group activity. Time is up. I would like to thank our two speakers, Wendy, Alexander. Thank you for your contributions here in the room. Thank you very much to our online participants for your contributions as well. And now, with no real break, we come back together in the plenary here and move on with the presentation of the results of the working groups. We need to wait for the other participants that will come back into the room. We have to reorganize the seating arrangement here in the room, and then we will be moving on in a few minutes.